This is Steve Zeltzer with WorkWeek, and I'm with Dr. George Rutherford. He's the Salvatore Pablo Lucia Professor of Epidemiology and Preventive Medicine, Pediatrics, and History with University of California in San Francisco. Welcome to WorkWeek.
Thank you so much.
Dr. Rutherford, why don't we first talk about epidemics? The epidemic the United States is facing right now is not the first one. There have been a history of epidemics that humanity has had to face. Why don't you talk about this history and what is the relevance of that history today?
Epidemic disease has been around since there were a sufficient density of humans to allow for transmission from person to person beyond kind of tight family tribal groups. There were several in classical times. There was a famous outbreak of plague in Constantinople in the 6th century, I believe. And it was it really sort of split a lot of the fabric of the Eastern Roman Empire apart. Everybody knows about the Black Death of 1349 in Europe, where the word decimate comes from, which killed a tenth of the population of Europe. There were other plagues that went on in London and elsewhere in Europe over the intervening years up until relatively more recent times. The U.S. has had a number of plagues as well. The U.S. Capitol, when it was in Philadelphia, had to be evacuated because of yellow fever, which is a mosquito-borne disease. And yellow fever was particularly pernicious through the South and led to the closings of ports like Charleston and New Orleans and even eventually up the river in Memphis. So we've had plenty of experience with plagues. In California, there was a plague there was true plague, not meaning like bubonic plague, in San Francisco in the early 20th century that led to the closing or locking down of Chinatown, because that was thought to be the source of it. And that was kind of a famous moment, relatively more modern moment in the history of epidemics. And then finally, sort of the next big one that everybody talks about, and we're looking to for answers now, is the 1918-1919 influenza pandemic, also called the Spanish influenza, which is a total misnomer. Spain was not a combatant in World War I and had a neutral press, so they were the ones who reported it first, hence the Spanish flu. That killed a lot of people around the world, maybe as many as 20 million at a time when the world's population was only 1 billion. There are at least 50,000 deaths in the United States from that, which has to be probably more than all the World War I deaths for the U.S. From all theaters, and then there's the big plague, which is HIV, which is still with us. We've been fighting it for now 40 years, and with starting to see the light at the end of the tunnel, especially in Africa. With relatively reasonable control here in the United States and in high-income countries, but this is I think quite unique in the history of modern epidemics. Given its prominence in the press, given its the sort of blow by blow that we're getting, it's almost like the first modern war to be reported on television. So we're seeing, I think your listeners are seeing the real kind of inside workings of how decisions are made and what the choices are for dealing with something like this.
And the development of science and medicine obviously has made real changes to be able to confront the development of these viruses and these plagues. Why don't you talk about the development of these technologies and practices and how that should help to prevent them or to help society deal with them?
Well, the era of modern molecular biology really stems from the period around and immediately after World War II, when we were able to develop, we really developed the technology for culturing cells so that we could experiment with agents to stop viral infections. At the time, the big killers were polio and measles. We were able to develop vaccines against both of those by the 1960s. I remember as a child lining up to get the oral polio vaccine, which is the Salk vaccine. It's now been we've now gone back to an earlier form that has fewer side effects called the Sabin vaccine, which is injectable. Measles vaccine came into the current measles vaccine came into common usage in 1968, along with soon thereafter followed by rubella and mumps. And it's there have been remarkable developments. I'm a pediatrician, and I was a fourth-year chief resident in the University of California, San Diego. We had an 8-bed ICU, and on any given day, 5 of those beds would be filled with children with a bacterial infection called Haemophilus influenzae type B, which caused meningitis and a whole bunch of other things. A really nasty disease, and we would see maybe a case a night. The vaccine was developed in the mid-1980s, which is now routinely given, and the disease has become so uncommon that among the pediatric infectious disease faculty members at the 3 or 4 big institutions in the Bay Area, only a handful of us have ever seen a single case. And I would not uncommonly admit 2 cases a night. So it's one of those things that just disappeared because of vaccine. I think the other kind of most recent lesson is with Ebola. Ebola has moved from a 90% fatal disease, 80% fatal disease with nasty, spread and difficult to control, something that's not only preventable by vaccination, but also treatable with monoclonal antibodies. And that's the new. I think Ebola is probably the best look at what really rapid advances in therapeutics and vaccinology can look like. Now, by rapid, in that case, it took a couple of years to get stuff into play, but it also took a while to sequence that, to get the sequences back from Ebola and some of the earlier SARS virus in 2002. The Chinese, who are tremendous masters of molecular biology, sequenced this new organism in 3 days after it was isolated. So it's the time frame has shrunk considerably, but that doesn't help with trials of vaccines because they still go into humans, and humans will be exposed or will not be exposed, and we'll see how well vaccines work. So that really is a year plus.
And the issue of SARS that developed, it did not really spread in the United States widely, and the effort to understand that and organize against it, it was a public health issue. How did the United States deal with that as far as protecting the people of the United States and actually protecting from similar diseases like SARS?
So SARS is a different beast, and SARS is a disease. I wouldn't say exclusively, but almost exclusively of the lower respiratory tract. People who get SARS get pneumonia. They don't have colds. They don't walk around. There can be sort of sprays created. So we got a break there, and we're able to go to school on what the Canadians learned about, how to deal with this in hospitals, how to deal with the healthcare workforce, all those things.
Well, the question for people in the United States and worldwide is the issue of public health and the support for public health, so that these investigations and studies of these diseases take place on a global level and that people are protected. Where have we fallen down on doing those kind of work?
There have been, following SARS and a lot of concerns about emerging influenza strains and the 2009 swine flu pandemic, which was not nearly as lethal as this. There were a lot of things put into place to try and prepare for the next pandemic. Among those were early warning systems that were funded by USAID to look at the human-animal interface, where most of these things come from human to human. Those were defunded here very recently, like in November or October. I don't know that it would have picked this up, but that's exactly the kind of warning systems that we have in place to look at this, at the human-animal interface.
And the Chinese, the one question that I have is they have what's called the wet market. where different kinds of animals and creatures are sold. And apparently this virus developed from the same market that the SARS developed. Why? What is the reason, and why didn't China shut down that market?
Well, it wasn't the exact same one, but the SARS was in Guangzhou, and this was in Wuhan, which are big cities, hundreds of miles apart. The Chinese have outlawed wet markets now in the wake of this. Then they're basically just live game markets, and I think that international pressure has led them to stop to shut these down. So it just becomes a fish market or a butcher shop after that. Everything's been processed and butchered someplace else. So that's one thing. That's one good thing that's come out of it. But yes, those are two examples. Plus, there was an exotic influenza that went through Hong Kong in 1997. It was also from a live bird market where people would buy live chickens for dinner. Those practices have been outlawed, and the Chinese do many things well, including enforcing laws. So I would assume that this is a conduit for emerging infections as being closed off. And
how has climate affected these influenzas and viruses?
Well, influenza is different beasts, but this is so. In terms of climate with COVID-19, there are outbreaks in the southern hemisphere right now. Now it's not quite still summer there, but they started in February, which would have been the equivalent of like September. No, it's like August, right? August for us. We would think that maybe there'd be some, you expect some dying down of transmission in the summer. But with influenza, that's probably more a function of the kids being out of school than anything else. Plus, influenza doesn't go away. It just starts circulating in the southern hemisphere and then comes back to the northern hemisphere as people start getting crowded indoors. And the reason they go crowded indoors is because the temperature drops. There's a tiny bit of research that would suggest that these viruses are more easily, these are animal experiments, that influenza viruses are more easily transmitted in cold, dry conditions. But on the other hand, there's just been a publication of an outbreak of COVID-19 from China where everybody got it as a sauna. So if you can imagine a hotter, wetter climate, I'll throw in with you. So I'd say that this is all supposition at this point in time. I think smart money says that this will continue to circulate at a low level during the summer here in the northern hemisphere.
And apparently China, South Korea, Singapore have been able to control and limit the pandemic. What were the experiences, the lessons that we learned from those countries versus what's going on here?
So China's kind of, let's set China aside, because they have the ability to do, they have quite a bit more control over their population, shall we say. South Korea is a very interesting point. Per capita, South Korea has 10 times the public health workforce that the United States does. Okay, and that's what we've disassembled over the lap since the 1980s. And it's when we need to be finding people and quarantining them and isolating them, that's a big deal. That takes a lot of person power to do that. We're fully building with repurposing people from all sorts of different types of jobs to help, at least in San Francisco, to help with contact tracing and also supervised isolation. Telling somebody that they're infected and they should go home and stay home, okay, that's fine, but you'd like somebody to come by and check on them a couple of times a day, make sure their oxygen saturation is okay, make sure they know they're not supposed to go out, make sure they have a plan for someone to bring them groceries. If they don't, or if they're in a living situation with a lot of other people, like in a studio, with 3 other roommates, there are hotel rooms that they can go to for homeless individuals. There are a variety of options that are being pursued, including trailers for people to stay in while they're in isolation. And similarly for quarantines for people who have been exposed but are not infected yet. So they're sort of incubating the disease, maybe, and we just don't know. So we pull those people out of circulation as well. Now, sheltering in place has the consequence of having everybody in quarantine. But as we move away from shelter in place, we're going to have to be more. We're going to have this kind of surgical precision about who gets isolated, who gets quarantined, and making sure they stay that way. That takes a big workforce.
And the issue of these cruisers now around the world, the Diamond Princess, the Grand Princess here, which is right now in the San Francisco Bay, and these ships around the world, what to do about the passengers and the crew, and whether or not you can have a quarantine on a ship and expect to control the virus.
I think we've learned the lesson. I think we've learned the lesson from that. That the answer is no. At least not in the way it was done. There was just too much mixing, I would assume. I don't know the specifics, but at least in the Diamond Princess, they went from tens of cases to hundreds of cases while they were sitting around in quarantine, which either says either there was mixing or the ventilation system or smart money says that it was probably the crew, which is younger, given that the median age on a cruise ship of passengers is pretty high. That the crew may have been infected or inadvertently infected, and they brought them food, cleaned the rooms, and did all the things that the crew does. That people may have come in contact with people who are infectious, or that the passengers themselves were mixing. I just don't know the details of it, but what I do know is that was a failed experiment.
So you don't believe that you can have a safe quarantine on a ship that isn't properly prepared?
I don't think so. I think that's going to be. I think that the lesson of the Diamond Princess was that, given the configuration of that cruise ship and the age and stability of the passengers on that cruise ship, and whatever the makeup, and how it was put together, that it didn't work. Could I imagine having a cruise ship where people basically had meals left outside their doors, really were locked in their rooms, had the windows open and still only went out on the balconies, and there was social distancing heavily enforced, like they used every other room or something like that? Yeah, I could envision a scenario in which it would work, but to take a crowded cruise ship with all the cabins occupied, I think that's a pretty tall order to pull it off successfully.
And another issue besides the protection of healthcare workers, and maybe you can address that, not having the PPE, are the millions of workers in the United States who are providing essential work, delivering meals, delivering supplies, UPS, Amazon, gig workers who are really critical when people are quarantined. Are these workers being protected, and what do you see as necessary to protect these critical workers?
Well, I think now that we've gone to this idea of everybody wearing masks when they go outside, I think that's fine. I don't think that hurts anything. I think it's helpful. I think that people who are coming in contact with the public, like people serving meals out of windows, they should be wearing masks. They should be wearing gloves. Gloves aren't foolproof because gloves are just like the next pair of skin, and if you rub your eyes, if you get them dirty, it's just as easy to inoculate virus. But I think we have to take precautions. I don't see those as the highest risk kinds of things, because you're not unless you're bringing food to people who are known to be in isolation. That's when you might want to think about, as we get antibody testing available, which we don't have yet. As we get antibody testing available, widely available, you can think about people who'd been infected before, and we knew they were infected before by virtue of the fact they had antibody. We could use them for some of those jobs, like a home care for people who are in home isolation, that kind of stuff. We had certainly had that experience with Ebola in West Africa, and it worked out pretty well. But there's just not going to be that many people who are going to get infected in this, at least in this wave of infection, and that's a good thing. And that's what all the shelter in place is about. And
how long are we talking about as far as the pandemic really becoming explosive, where hospitals cannot take care of people who get them, or potentially not take care of them, and then even if there's a decline in the rate of exposure, that continuing until 18 months until an antibody is developed.
Yeah, well, we have to get a vaccine first. That's the only way we're really going to control this. This disease has too high a risk of mortality and severe morbidity associated with it. Just let it run through the population and say, everybody get passive immunity, which is kind of what they're doing in Sweden, frankly. And I think I think that's a somewhat foolhardy approach. We will see new outbreaks from time to time, which is why we need this very aggressive contact tracing and supervised quarantine and isolation and aggressive case finding. Because instead of just sort of saying, everybody stay home, shut the barn door, we're going to have to say, okay, here's one case here. Okay, let's go do a quick cluster outbreak investigation around that person. We'll get all those 6 new people identified and isolated or quarantined. And so that's the idea. That's what we're going to have to replace shelter in place with, and that's a big infrastructure to put together in a relatively short period of time.
And you mentioned earlier about the decline in support for public health care over in the 80s, where it was cut back, and the lack of public health care, the whole healthcare system. What do you foresee the necessity of in developing or building a healthcare system that is capable of really taking care of people in this country?
So I'm not talking about healthcare per se. I'm not talking about patients in front of doctors or patients in hospitals. I'm talking about public health, which is this sort of invisible function of government that people don't see. They may see restaurant inspection, grades or something like that, but it's a big kind of medical, nursing, public health professional infrastructure that does everything from tracing patients with tuberculosis to sexually transmitted diseases to doing the kinds of surveillance we need to understand where diseases are spreading, to running big public health programs, public health prevention programs. It's really about preventing disease, the primary prevention of disease, better engineering things, for instance. And so that's the part that's been stripped away. I think healthcare's, in pretty good shape until it gets totally overwhelmed like this. And, we have the most advanced healthcare system in the world. There's no two ways about that. But we've also had the public health system on which it rests stripped pretty bare underneath it. And that's what we're seeing now. Well, that's one of the reasons that we're going to have to build it up very quickly in order to replace shelter in place.
And the bidding that's going on, there's a bidding war on who's going to get masks, who's going to get PPE. Do you think this should be allowed?
It don't happen that way in China, believe me. It's crazy. It's crazy. You need centralized leadership for this sort of stuff. To have the states bidding against each other just makes the rich richer, and doesn't help the delivery of the absolutely critical delivery of care. It's not a good thing, and it needs to be managed at a real central level. Now, whether it can be managed with the kind of fine attention to detail. So let's say Zuckerberg, San Francisco General, needs 100 face shields tomorrow. Is that something that can go up to Washington, come back down and get 100 face shields tomorrow? We have computers. I think that's not out of the question. And it's, beats the hell out of everybody bidding against each other and some getting stuff and some not getting stuff.
And the development of computer technology, the internet, apparently China and South Korea have used technology to learn about the disease and track things. And how have they been able to use their technology to an advantage as far as protecting the population, understanding the disease?
Yeah. Well, it's about being able to understand who's where, when, right? And they have somewhat different views on privacy in society than we do. I could put an app on your phone. I could mandate that you had put an app on your phone tomorrow, that tells me exactly where you are every moment of the day. Okay? And so that if you become a case, I can say, okay, this is where you were when you were most likely infected, or this is where, so you came out of your house on let's say you're a case on Tuesday. So you say, okay, last Thursday, when you were most likely infected, you went out to the Safeway someplace, or I don't mean to pick on Safeway, but some grocery store someplace at 5 o'clock, okay? We also know that these other 15 people were at the Safeway at 5 o'clock as well. Their phones go beep, beep, beep. You may have been exposed, come in and get tested. We also would know that if you were diagnosed on Tuesday, you were probably infectious on Sunday, that you were shedding virus on Sunday and Monday. And we could see where you were during those 2 days and, warn people who may have who were in the same time and space coordinates as you were. Now, that's awfully big brotherish. And I don't know that we really have the tolerance for that. I don't know that we're willing to go that far. I think it's a very open question. What we can do is ask people for their permission to look at their phones and say, okay, last Thursday you were at this supermarket between 5 and 6, and then we could go set a table up out of the supermarket and say, if you were here last Thursday between 5 and 6, please come here and get tested. Right? I mean, we could do something like that. But just imagine, somebody walked through the airport. Well, there are only 10,000 people who walk through the airport. There are going to be limits to that technology. But most of the transmission from China, between 75 and 85 of all transmissions occurred in households. So that's where we're looking now. And then as we get additional workforce and we get additional sort of probably less intrusive technology available, we can go out and start looking for community contacts. Most of them are going to be in workplaces, maybe markets, pharmacies, kind of the essential businesses that people go to.
And the issue of sanctions, the United States has tariffs, it has sanctions on Venezuela, on Cuba, on Iran. Apparently, Iran is in a horrific condition of not being able to get medical supplies. What are your views about pandemics and the effect of sanctions and these kind of actions that prevent countries from getting supplies, medical supplies?
Well, it's a problem, obviously, and that's why we have the World Health Organization to be able to work around inter-country problems. So I think that we have international organizations whose role it is to make those things, is to work around those things.
So the idea of one country being able to survive this alone, you don't believe that holds water?
China, which is probably the best equipped to do it, failed to. So I think the answer is no.
What are your hopes about the future for the United States, for the American people? Because there is a panic. It could grow if the transportation system collapses. What do you see the future in this country with this pandemic where we don't have something that can deal with the virus?
Well, we will have something that can deal with the virus, and we will have a vaccine. I mean, that's just a matter of time and some luck. Everybody's out, complete, gas pedal to the floorboard trying to find this stuff, and we'll hit it. I mean, if we can find something for Ebola, which is a lot more complicated to treat, we can find stuff for this. There are any number of drugs that are being evaluated right now. So I think the short-term hope is that we'll be able to treat this, and so you can cut down the mortality rate. Hopefully we can find something that's effective against the virus itself rather than the consequences of the infection, like the immunologic storm that's what's killing people. Hopefully you can find something that's effective against the virus that we can give people, as soon as we diagnose them, to stop the virus from replicating and also stopping them from shedding, from infecting other people. That's one of the great advances in HIV. We can not only stop the virus from replicating, but we can stop it from being transmitted. So that's what we're hoping for. Obviously, longer-term solutions with vaccine. But until then, we have to temporize. And I think that this is an object lesson for people around the world that pandemic disease is always going to be with us. It's been with us since the dawn of humanity and will continue to occur. Our job as citizens of the world is to support functions, which may be governmental, they may be non-governmental, they may be international, whose job it is to plan for these things, to assure adequate and up-to-date stockpiles, and to be out looking for these things before they occur. There are at least another 3 or 4 bat-associated coronaviruses that could cross over. And we will likely see, that's what SARS was, by the way, and I would not be surprised to see something cross over in the next 15 or 20 years, and that one we need to be prepared for.
So this is an ongoing, continuing challenge for humanity. That's what you're saying?
As long as we're not the only species that lives on the globe, yeah.
Okay, well, I want to thank you for joining us on WorkWeek. We've been talking with Dr. George Rutherford, who is a medical doctor and expert on epidemiology at the University of California. Thanks for joining us, Doctor, this afternoon.
You bet.